Well, again, I want to just welcome everyone to the session 2 of our Walking in Two Worlds Behavioral Health Challenges of Living in a Non-Native World. Challenges of living native in a non-native world. This series is brought to you by IHS in collaboration with the University of Iowa and the Native Center for Behavioral Health. We are working with Donna Enfield, and I am with the Native Center for Behavioral Health. My name is Steve Steiny. We're located at the University of Iowa. I have Jeff Ladolter on, who is a colleague of mine, who will be assisting with technical issues, anything that may come up. We have our presenter, Mr. Ed Parsells, and of course, Donna Enfield is here as well. And we may outnumber the participants today. So this is a great teacher-student ratio, I think. You don't get this very often in today's world. So we're really happy to have the three of you with us, and maybe we'll have a few more join us as we get started. I just have a few introduction slides to go through, and then I will turn the floor over to Mr. Parsells to present today's topic, which will address, this is a two-part topic. We're going to address today Native American Stimulant Use Disorders, looking at this as a continuum of care. So this will be kind of an overview, and then what we're hoping to do is gather some feedback from all of you about what you would like to see part 2 focus on. And you'll have some choices to choose from in a short polling question at the end of today's broadcast. So really happy to have everyone here. Hoping we might get a few more to join us, but I think the really important people are here today. So happy to have all of you here. Just like I said, we just want to go through a few slides here before we get started. The Native Center for Behavioral Health. This, as I mentioned, this project is supported by the Native Center for Behavioral Health and the University of Iowa. The content is developed by the presenter, and the opinions expressed do not necessarily reflect the views or policies of the Native Center for Behavioral Health or the University of Iowa or IHS. We will be offering links and PDF versions of the slides from today's broadcast. And Jeff, if you will double check to make sure that we are recording this event, because I know we'll have a recorded version available as well in our Native Center for Behavioral Health archive, YouTube archive. And as okay, thank you, Jeff. And as most of you are aware, we are offering NADAC approved substance use CEUs, or we also are working collaboratively with the University of Iowa's School of Social Work for social work approved CEUs. So we will just be reaching out to you following today's broadcast, and you should be able to let us know whether you would like the NADAC or the social work CEUs. Although we are gathered virtually today, we want to take a few moments to acknowledge the land and pay respects to those indigenous nations whose homelands were forcibly taken and inhabited. Please take a moment to read this land acknowledgement that was created by 3 members of our team, Ella and Keely Driscoll and Sean Bear. Thank you. Well, Ed, where did your bio? Where did it go? Wow. Oh, well, I'm having trouble with the slide. It's like it's well, without further ado, I do want to introduce Mr. Ed Parsells. He previously served as the director for the Rosebud Sioux Tribe Adolescent Residential Treatment Program and has received his Bachelor's of Science degree at the University of Oklahoma City. Ed is a friend and a colleague and has worked in the field for many, many years. And I mean that with the utmost respect. He has co-authored the South Dakota statewide Native American Substance Abuse Needs Assessment. He has administered an Indian Health Services grant that mobilized community response teams on 19 reservations to address fetal alcohol syndrome. He has served as consultant for our center and has also been involved in a number of different curriculum development initiatives. He has served as the charter chairman for the Great Plains American Indian Credentialing Board. Ed has a vast experience both clinically and administratively working with substance use disorders, and has also authored the 7-direction model, which is a culturally based substance abuse treatment model. This model incorporates traditional Lakota culture and values in a curricula that includes evidence-based practices to treat substance use disorders. So I'm really pleased to have Ed Parsells here. I'm sorry I'm having a glitch on my slide there, but you can see Ed's got a nice fish, and I think that's his granddaughter with him. So, Ed, we're really happy to have you here with us. I want to turn the floor over to Ed. I'm going to pull my screen down and let him get his slides up. So I'm going to take my screen down. There we go. Okay.
All right. Are mine up?
Yes, I can see them, Ed. You may want to put them in presentation mode, but yes, we've got slide 1 starts with special acknowledgement. So, Ed, thank you so much for being here, and really looking forward to hearing your presentation
Okay. Thank you, Steve. And yeah, I'm just delighted to with this opportunity to share my experience with addressing the problem of meth use disorder in Indian country. It started on the Cheyenne River Reservation.
Ed, I want to stop you just for a moment. You may want to get your slide presentation into a different setting. So into presentation mode. You had it earlier, but we can see the notes section and the slide deck on the left.
Okay, let me
get her set there so the audience can see the full screen. Yeah, Jeff says Alt F5 will get you there. I know you had it up earlier, Ed, when we were testing it.
Yep.
Oh, John, it's good to see you there in the audience. Thanks for joining us.
If it's going to hold things up too much, maybe we could go ahead with the view that he had for the sake of time.
Well, sure. And I'm happy to pull your slides up, Ed. I can advance them for you if you'd like to do that. That'd be easier for you.
Did
Oh,
they,
there we go. I like that.
Perfect. Thank you.
I like the looks of that, Ed. Wonderful.
all right. Okay. So again, I'm delighted to be here today and to share my experiences in addressing meth use disorder in Indian country. Again, it started back in Cheyenne River back in 2015, and then I served as a consultant there, and I kind of got baptized with fire regarding meth. They were experiencing an epidemic, and I didn't have a lot of experience with meth back then, but was faced with many situations that I never experienced before in all my treating of substance use disorder, and had to educate myself very quickly on what was happening in the realm of meth use disorder, and made some fascinating discoveries. And then, of course, after working a year in Cheyenne River, went to Rosebud, and they asked me to help with the residential meth treatment program, and I stepped into that role and continued on. And then we developed this 7-direction model for addressing meth use disorder with the Rosebud Sioux Tribe's meth rehabilitation program. So since 2016, I was the unit supervisor, basically clinical director, administrator of the meth program. And it was a fascinating experience, and we learned a lot about meth over those last 5 years. And I retired a couple months ago, but I have a private practice, and I still do meth treatment in an outpatient setting on the Rosebud Reservation. But I do want to acknowledge the Rosebud Sioux Tribe and the opportunity I had there, 2016 to 2021, working with the residential meth treatment program. Cardwell Knuckles is a neuroscientist, and he's been a mentor of mine for many years, and he's also a good friend. We had Dr. Rebecca and Dan Foster on contract with our meth treatment program. They're both psychologists, and they served as a team, helping address the psychological issues and making referrals for psychiatric care for many of our clients. Russell Eaglebear is a relative of mine. He's a Sicangu chief. He's a spiritual leader, a Sundance leader, and deeply rooted in traditional Lakota ways. So, and he's also a mentor. Richard Mooskamp, a spiritual healer, a spiritual leader, a Sundance leader among the Oglala Lakota. And I had him on contract as well. He was our cultural, spiritual leader. So he ran our sweats. And if anybody wanted to pursue Wolakota as a way of life, then he was available to them. Fred Little Bald Eagle, also on staff at the Rosebud Sioux Tribe Alcohol and Drug Treatment Program. Very instrumental, fluent Lakota speaker, and he served as an advisor as well and a helper in our program. So just want to recognize this group. Without them, we would not have had program at all, but with their expertise, we did some meth treatment, and it continues. So today we want to share with you through this presentation some of the demographic information of stimulant use in Indian country nationwide. And we also want to compare that with the non-Indian world, so we have some information regarding that. Protective factors in Indian country, and this primarily we're talking about the culture, dynamics, elements, principles operating within the culture that can be useful in addressing meth use disorder, and also our 7-direction model and other venues that are of take into consideration Native American culture in addressing substance use disorder. So here's a graph that kind of shows a comparison. So on the left, a group of graphs addressing cocaine, and then next is crack cocaine, and then methamphetamine. And you can see the purple bar is American Indian Alaska Native. And you can see that the prevalence there is higher than any of the other ethnicities. And also a significant factor on the right-hand side, stimulant misuse. This is primarily prescription misuse, as well as street methamphetamine acquired from the street that may have come through pharmacy, perhaps Indian Health Service pharmacy, and now it's being sold in the street. So this demonstrates the prevalence. Also, here's another set of graphs with the ages, age 12 to 17 on the left. 18 to 25 has the highest prevalence. And then older population, 26 and older, is a set of graphs on the right. And the comparison there, the bar graph on the right compares the overall population in the United States compared to Native American meth misuse. So among Native Americans in 2018, it's 2.5% of the entire population, versus in non-Indian, the rest of the United States, it's only 0.8%. So you can see the use is greater. I had somebody call me up and say, how do you say meth use disorder in Lakota? And I was like, good question. So I contacted our spiritual leaders and I posed a question to them, and they said, we don't have a term, there's not a word that specifically identifies meth use disorder, but they said, tell us what you know, and we'll have a discussion. So over the course of about 3 months, I had lunch once a week, sometimes twice a week, with the traditional leaders, the spiritual elders, and I shared with them what we knew clinically about meth. And this is a term that Richard Mooskamp came up with for Lakota, Iglu Daganishni. And that term is it's a very powerful term. Iglu Daganishni, it means like in for Native American culture, we're all on a journey. We're moving through time. And you've traversed across time from yesterday to today. So this term kind of captures that your journey is to absolute oblivion. Everything in your life is being consumed. People who suffer from meth use disorder, severe meth addiction to meth isn't like any other addiction. The severity of the use disorder, the impact of the use disorder, basically a meth high is nothing more or less than pure 100% brain damage. It's not like any other substance. So people who are caught up in meth use disorder severe are on a journey to absolute oblivion. Dreams and goals. We've seen people who were high functioning and with the meth use disorder within a very short period of time, their life is on a downward spiral. Everything that they aspired to is now gone. Educational, vocational, family relationships literally disintegrate. I've seen some of the, you talk about burning bridges. We had the one lady, I called her mother up. She was in treatment and we were going to have family week. So she wanted to invite her mom to come and participate in her treatment. I called the mother up and the mother said, you tell her to complete her treatment, stay sober for about 3 years, and then have her call me. Anything short of that, I will have nothing to do with her. I completely disown her. And oh, hell no, I'm not going to participate. You know how many family weeks I've participated? You know how many times we've had our hopes up that something was going to happen with her and just refused to participate. Had another young lady I served as a expert witness for the defense. She was going to have her parental rights terminated, and I was in the court hearing with her. And they asked me about success rates of meth treatment, and I shared the options and put a pretty optimistic spin on things. And they asked her if she was willing to cooperate to save her kids. And she said, no, go ahead and take those kids. I don't want them. If I want kids, I'll make some more. And she chose to continue on in her relationship, primary relationship with meth. Even animals have a strong instinct to take care of their young. Humans have a stronger instinct to take care of family and kids especially, and meth will absolutely, I've seen it completely destroy that, like no other substance. I mean, over the course of time, people suffering from all types of use disorder are gonna give priority to the relationship with the substance, but with meth, it's extreme. Their life is literally on a downward spiral, out of control, and the end of the trail is jail, prison, insanity, institutions, or even death. So that's iglutagonishny is the term that Richard Muskamp came up with to describe meth use disorder. The opposite, igluwashake, is the term that was used for people who are in recovery from meth use disorder. And the journey is an upward spiral, restoration of goals and dreams. And if they didn't have a strong sense of purpose, then that's what can develop. Everything good in a person's life is enhanced. This is in recovery. Dreams and goals progressively realized. Relationships, family relationships are strengthened, and work education, achievement, and sense of purpose is can be established or restored in the recovery process. So in our 7-direction model, we recognize that there are 7 aspects of the use disorder: physical, mental, spiritual, emotional, social relationships, spirit relationships, and a person's relationship with self. This is what we address in the treatment process. So, and I'll share more about each of those a little bit here. So I came back to Rosebud in 2002. I worked for IHS for a while, and worked in a couple of treatment programs for IHS, and then got recruited to come back to Rosebud. And I did work for the adolescent treatment program, and I saw meth as it kind of came. It was like on a roller coaster, so it would come in waves where meth use was rampant, and then we had a young girl who overdosed on meth and literally damaged her brain. She wound up in a state hospital and came back with a diagnosis of meth use, meth-related psychosis, which is equal to paranoid schizophrenia. And she was, the kid said, she got a bad batch of meth. Well, it wasn't a bad batch of meth. It was just meth, and that's the effect that it had on her. And when that happened, she was fairly popular. So the popularity of meth kind of went away after everybody saw what happened to her. But then, a short period of time, here it comes again. So it's like been on a roller coaster. But in 2017, 18, I know the data showed that nationwide there was kind of a decrease in meth use, but I know on the Rosebud it was epidemic. And in 2019, it was the director of the adult detention, adult correction center, the tribe's jail, said that over 90% of all that were incarcerated, all of the arrests were directly or indirectly related to meth use, abuse, misuse. So, and again, depending on how a person is raised, Sean points out that some people, if they're raised close to their culture, substance use takes on this form. If they don't have a sense of relationship with the culture, it can take on a different form. And then also the contrast of urban versus reservation life. The substance use disorder, meth use disorder, can take on a different dynamics based on how a person is oriented to their culture. Traditional versus bicultural versus assimilated, I guess, is so methamphetamine, the major mode of action is that meth will damage the brain and cause a release of norepinephrine and dopamine. Dopamine is associated with euphoria. So people who abuse, misuse meth talk about a rush, a blast. This is the onset of the intoxication, where the brain is literally flooded with dopamine, and the euphoria is pretty intense. Methamphetamine, it also resembles neurotransmitters, so that action in releasing dopamine happens, but there's also another action where the brain is literally damaged and dopamine gets dumped. And then there's a pump that inhibits the release of dopamine, so it shuts off the dopamine from naturally being released. Well, that's damaged also. So you have a tremendous amount of dopamine flooding the brain. So a meth high is literally a natural high. It's literally a natural high. The meth doesn't produce the high. The meth damages the brain that causes the natural dopamine to be dumped. And that's what a meth high basically is. Brain damaged caused a flood of dopamine in the brain. Now, repeated meth high can produce meth-related psychosis. Now, I got flagged. I got to serve on an expert panel and got to go to Rockville, Maryland, and meet with some of the top experts in the field of stimulant use, and I got red flagged with anecdotal information, but I'm gonna share it with you because it's important. It's been my experience, and disclaimer: it is anecdotal. I have never, ever encountered, engaged, treated, or assessed somebody who experienced meth use disorder that did not have some type of history of meth-related psychosis. Not a single one. Now, the literature says up to 60% potentially. So that's what the research has shown. But my experience in doing an assessment with every single person that we've ever assessed for meth use, you let me talk to them, I'm going to give them permission, and they're going to share with me their experiences with meth-related psychosis. Quite often it's with acute intoxication, and sometimes it's also associated with sleep deprivation caused by the meth. But this meth-related psychosis, it has been 100% with everybody that I've assessed. So, that's again, anecdotal information, but it needs to be researched, needs to be studied. But this meth-related psychosis can damage the brain. Meth can damage the brain, where somebody could get a meth-related psychosis diagnosis and need psychotropic medication, antipsychotics to quiet auditory, visual, tactile, and olfactory psychosis hallucinations. So, and I've seen them all present with people in treatment, either by history or actively experience these things. Had one person who failed in a meth treatment or a regular treatment program. They got referred to a meth specific treatment program. They failed in that treatment program, and then they came to our program. They had no history of meth related psychosis. While they were in our program, they got diagnosed with meth related psychosis. They got sent off to a psychiatric hospital and was put on medication for meth related psychosis. They had hid it in their previous treatment experiences. They wouldn't talk about it. They wouldn't share it. They wouldn't own it. We gave them permission to share it and own it, and they got diagnosed and they got medicated for the meth-related psychosis. Sometimes it'll resolve itself over time. A year or two out with no meth. I've seen people that had the diagnosis and they sustained abstinence from meth use, were actively in recovery, and came off the medication. I've seen that happen. I know another young lady, she had the auditory hallucinations, and she wound up committing suicide, unfortunately, but she had meth-related psychosis 6 years out. And she told us before she left our program, she told us that the medication kind of quiets the voices down, but it doesn't eliminate them. And she said that if she, in her mind, engaged the voices, they were full on, even on medication. But she said with the medication, she could try to ignore them and diminish their effect. But she was impaired for 6 years that we knew her, worked with her in treatment and in continuing care. She continued to relapse and eventually committed suicide. Very sad case, but it appears that it can produce permanent brain damage. Again, most are going to recover. A lot of them, the meth psychosis is going to be transient. It's just during acute intoxication and maybe in protracted withdrawal, they're going to experience some psychosis, but a lot of them, it's going to resolve. But for some, it's not going to. Psychiatric care needs to be incorporated and included with meth treatment. When people start engaging clients and they start talking about their meth-related psychosis, then referrals need to be made, and psychiatrists need to be available to help with their care. So here, more illicit drug use among American Indians, Alaska Native. Marijuana has the highest prevalence, 23%. Psychotherapeutic drugs, primarily prescribed medication that's being misused and abused, 7.6%. And then methamphetamine, 2.4%. Followed by cocaine, hallucinogens, inhalants, and opioid. So best practices addressing meth use disorder. We took those 7 elements, aspects of a person's life, and put together a treatment protocol for each one of those. And we called it the 7-direction model. Now we incorporated the matrix model. I've been trained in the matrix model. I've been trained as a supervisor for the matrix model, and I've talked to the matrix model, the people that have this model, and asked them if we can adapt this to an inpatient setting, because the matrix model is primarily outpatient. And they said, how so? So I had the dialogue with them, and they gave us permission to use principles of the matrix model and incorporated that into our residential treatment program. Now, the 7-direction model also has an outpatient component. We use the matrix model with that in continuing care as well. Another one is motivational interviewing. And again, I call it the inside out approach, but it's basically motivational interviewing, and we've adapted it to the culture. So we have a version of motivational interviewing, and again, the Brian Cerna with motivational interviewing, he helped us with this adaptation. And there's other products as well, integrating Native culture. I know they did some in the Southwest, as well as in the Great Lakes region. Some work had been done. The other one is rational emotive. I love rational emotive cognitive behavioral therapy because it allows us to look at things that have happened in the past and how they can potentially shape irrational beliefs, thoughts, self-defeating thoughts that are caused from history. We get to address that with rational emotive cognitive behavioral therapy. Dialectical behavioral therapy, Dr. Dan and Rebecca Foster, they're both trained and credentialed with this, and they also use this in our program. The entire meth rehab program, Dr. Cardwell Knuckles, he's retired. He's a world-renowned author and an expert in neuroscience, and he kind of befriended us and helped us develop our program. So Gib Sedback, he was the director of the Division of Drug and Alcohol Abuse in South Dakota for many, many years. In 2005, I believe it was, he allowed me to help create an instrument to do a statewide substance abuse needs assessment. So I got to be a part of that back in the day. They did the statewide needs assessment, and one of the glaring facts that came out of the survey, and Gib Sedbeck was dramatically impacted with that finding. Native Americans that practiced their traditional cultural beliefs had a lower incidence of substance use disorder than those that didn't. That was a glaring statistic, and he said that dramatically affected him. And it's primarily the spirituality of those cultural beliefs that the closer people were to their culture, the less the incidence of use disorder. So practicing cultural, spiritual beliefs, one is preventative, and also those who have fallen away from that to re-engage the culture, it can be useful in treatment. White Bison, Don Coyas, he with the White Bison organization did an adaptation of the 12 steps. Basically, it's semantics, the working principles of 12-step. He wrapped native thought and language around the 12 steps. And basically, culture is prevention. We didn't engage in any type of recreational use, illegal, illicit use of substances. So that's in our culture. And then also the ceremonies and spirituality are preventative, as well as can be used as in the treatment of substance use disorder, stimulant use disorder. In our 7-direction model, we took the Prochaska di Clemente stages of change, and we found a cultural adaptation with Iknomi, Mato, Taksha, Tatanka, and Wambli. These are Lakota terms. The first one is the spider, Iknomi, for pre-contemplation. And again, the denial, deception, Iknomi is the spider web being trapped. And we had an elder, she said that and this was in the adolescent program when we were developing this, she said these kids, when they get it, it's almost like the lights come on, and they're like a bear coming out of hibernation. So their eyes are adjusting to the new light, enlightenment. They're hungry for information, and they can be a little grouchy as well. So raw emotion. So the bear, the motto, kind of symbolized that contemplation, where you had pre-contemplation before, now it's contemplation. And then the taksha, the deer. So there's like a hyper vigilance. Deer are hypersensitive to danger. And we recognize that adolescents, when they really engaged recovery and treatment worked for them, they become hyper vigilant of relapse situations. And there's just a heightened sense of awareness, and they become focused. There's like the push and the pull in recovery we talk about too, that sometimes circumstances can push a person away from recovery, and the desire for engagement can be pulling them into recovery. So you have those two dynamics. The Tatanka is a buffalo. So here, a person practicing recovery and modeling it, they've discovered what works, and they're using what works. So the Tatanka symbolized strength, and then the Wambli, the eagle, symbolized mastery. So this is the maintenance in recovery, taking cultural spirituality, relationship with the creator. And so these are what we did with the 5 levels of Prochaska di Clemente's theoretical stages of change. So this is a cultural adaptation of that built into our 7 direction model. Now this is of significance. 44% of the women, 24% of the men entering treatment for meth use disorder have a history of sexual abuse. I think across the board, many people entering into whatever substance use treatment have a history, but this is very significant for us. And then 32% of the women, 34% of the men, childhood physical abuse. So these experiences, if I could just break it down and make it real, they create kind of a yuck factor, something running in the background in the psyche, mentally and emotionally, that creates this dis-ease. And when substances come along to create this artificial sense of a high, they can medicate this discomfort of this stuff that's running in the background for people. So they're susceptible. And meth is a very, very powerful means of medicating emotional pain and discomfort. And then 56% reported a parental alcohol or drug problem. Now, for me, this statistic, it's not just reflecting that parents openly used and abused alcohol and drugs, and that was on display for the kids or children, but more importantly, if they in fact were suffering from severe use disorder, then along with that comes emotionally absent parenting, as well as potential neglect and maybe even abuse. So it isn't just that they modeled use disorder, but there are other dynamics that are factored into that. And then the multi-generational dynamic of substance use. We know that there's a very high percentage of people who suffer from use disorder have parents that had use disorder. So it's multi-generational. Whether it's genetic or social learning theory, you take your pick, it's going to impact generations. So with the stimulant use disorder, we have these syndromes. The first one is toxicity, and then abstinence, and then this thing, the matrix model, they termed as the wall. It's like this emotional roller coaster. It's a it's a fascinating phenomena, mentally and emotionally. Every person suffering from meth use disorder that we encountered, you can just see this. It's pronounced, and after the protracted withdrawal, then comes a whole set of symptoms. It's referred to as the wall, and this is where a lot of people are going to bail out of their recovery experience. And then post-acute withdrawal up to 2 years potentially after the last use. Talk a little bit more about that. So here's again the graph showing the stimulant use amongst Native Americans, and again the blue on the left, 2015, just compares the years, and then the green, 2016, 2017, and 18. The gray and the blue among population aged 18 to 25, 2.6% of the population abused stimulants, versus overall US population 6.5 during this time period. Again, this slide we showed earlier, 2.5% age 18 to 25, and the overall population 0.88%. So you can see the difference. Native Americans have a higher incidence. So here's another one, the meth highest among 18 to 25-year-olds from 2017, 2018, there was a decrease in use, but it's still higher than the general population. And then the prescription stimulant use, and again, this probably coincides with Avis did a presentation on the diagnosis of ADD, ADHD, and those are potentially treated with stimulant or amphetamine or a similar acting drug, and that can initiate the use of stimulants, causing misuse and potentially severe misuse. And then cocaine, again, decrease from 2017 to 2018, but again followed up with an increase. So meth, it's leading to the highest numbers of substance abuse inpatient admissions behind alcohol. So it has continued to increase in prevalence. And Native American communities, the FBI, Department, the Bureau of Justice, the last couple of years for South Dakota, they've been involved in the state's meth summit every year, and they put on some pretty dramatic presentations on how gangsters are gaining access into Indian country, targeting the women, the young ladies, befriending them, developing romantic relationships, and by that means gaining access into Indian country. Primarily, gangsters from the cities, Mexican drug cartel, that type of thing, are gaining access into Indian country, targeting the women. And then also they're saying that many of our reservations are understaffed and underfunded, and with policing and law enforcement, so they're a little softer targets in Indian country than other places. But in 2008, meth was identified as the greatest threat to our communities, and that come from tribal law enforcement agencies. I remember my son and I like to go deer hunting. So a couple of years ago, we went out into the country and watched the sun come up, and was looking for deer in some of our favorite places, and was out there, and it was just at the crack of dawn, and I heard this strange noise, got louder and louder, and here there was I think it was a C-130 transport plane with propellers on it, and it was an older model, and it was flying very close to the ground, and we watched it, and it landed on the prairie out in the middle of absolutely nowhere. I mean, it was absolutely the middle of nowhere. Here come this big airplane, landed out on the prairie, no landing strip, no airfield, landed on the prairie. We watched it land, and then we watched a couple of pickup trucks go up to that plane, and they unloaded something out of that plane into those trucks. And I got kind of spooked. I'm like, man, let's get out of here. We're witnessing something potentially seriously illegal. But that was probably, I don't think they were bringing food and clothing to the needy Native Americans, and this was on a reservation. But the drug cartels are actively involved in Indian country, and with that glaring statistic coming from the director of the jail in Rosebud, 90% of all arrests are meth specific related, directly and indirectly. So either arrested with meth, or crimes resulting from meth use, misuse, assault while intoxicated, that type of thing, or trafficking, or other burglaries, and other types of crimes, but they're all somehow associated with the meth. And it is nationwide. You see a wide variance of use and the impact. So some tribes, it's minimal for now, and then it was bad, and then it got better, and then it's now it's worse. So it's kind of a dynamic problem, and it varies from location to location, but in general, it's an increasing problem. So again, our statistics, this graph on the left, cocaine, crack next, and then the methamphetamine. And again, this is 2018 or 2019, and it shows that American Indian, Alaska Native, 2.4% of the population. That's a pretty And by state, South Dakota has the highest incidence rates of misuse of stimulant. The number of drug cases and arrests conducted by law enforcement increased substantially since 2011. 2018 overall increase of 47% of the number of drug cases. This is coming from arrests and convictions related to directly and indirectly related to meth or drug use. Well, here's our 7-direction model. It got looked at, and our success rates were equal to that of other treatment programs and protocols. And the 7-direction model got looked into, and we were selected as one of 3 model treatment programs in the country to address stimulant use disorder. But what we did was we took those seven aspects of a person's life and made a direction out of each one of those. And so we had 7 directions, 7 what we refer to as life powers, and then 7 Lakota values. So those 3 in sevens, we took an entire week to address each one of those. So it's a 7-week program with 1 week. It's actually 8 weeks, but it's 1 week with each direction, and then another week to summarize and put things all together. So starts with the west, the direction, the north, the east, the south, and then below that's earth, and then above the spirit world, star nation. So those are the 6 directions. And then the person's relationship with self is the seventh direction. So we have elements of this for prevention, inpatient and outpatient, and continuing care. So here's a couple of people that successfully graduated from our program, and these are some quotes from them. It said, one of these has had continuous sobriety since 2016. He was in that first group, and he's had continuous sobriety. The other one had, I believe it was like 3.5 years, and then he relapsed, but then got back into recovery. But these are a couple of our success stories. Rosebud Sioux Tribe Meth Rehab Program not only taught me about my addiction and why I couldn't stop using meth, it also taught me how to live a spiritually, mentally, emotionally, physically fulfilling life. And I love this statement. I no longer need to look outside myself for validation. We teach people that they get validated by the Creator supernaturally, internally. They don't need validation externally. And then the other one, the Meth Rehab Program gave me an opportunity to take a good hard look at reality. Treatment, I was able to find my true self. We talk about the dysfunctional person that developed as a result of meth use disorder, and they discover their real self, their true self. I was able to see all the wrongs I did to others and myself. Finding spirituality helped change my life, and the meth program equipped me with the tools to stay sober. In recovery, I'll continue to work my recovery program using tools and skills taught by the meth rehab program, their 7-direction model. So meth use disorder, first of all, it is a long-term, it's a process. The neuroscientists tell us that it takes about 2 years for the brain to completely recover. It takes a year for the endorphin system, for the depletion of dopamine to return to something near normal. It takes a full year for that to happen. There's been a lot of brain damage that was done in the process of misuse of methamphetamine, and the brain is just fascinating how it can recircuit around damaged brain material. And in the process, if we can help a person to cognitively engage in the recovery process as the brain is healing, we have an optimum prospect for recovery. Some of the more difficult clients that we've engaged are the ones who went to prison, who didn't receive any treatment, and the brain literally healed up around dysfunctional thinking. And then we get them into treatment, and they're a more difficult client than the ones that if we can get them at the end of their addiction and engage them for 6, 8, 9 months in a solid, concrete, structured recovery program, as the brain is healing up, they have the greatest prospect of successful recovery. And again, the seven elements: mental, emotional, spiritual, physical, spirit relationships, social relationships, and relationship with self, each of those being addressed with activities around recovery and engaging recovery. Questions, comments, debate? Anybody want to fight? I don't.
No fights with you, Ed, but I'm just wondering if you could take just a few minutes to maybe speak about some of the other stimulants. I'm thinking in particular about like the monster drinks that are highly caffeinated, just caffeine in general, and how might that influence the brain recovery is one question, or just separately, because I know I've seen there was one individual I'm thinking of in particular that presented to the emergency department that the staff thought that he was having an anxiety attack, and it was an overdose of caffeine. So can you speak just briefly about that? I know that could be a whole nother webinar, but for a moment.
It is. And I was a little surprised because, I'm old school treatment, and back in the day, we cut off all caffeine in our treatment program because, it was a stimulant, and it's also addictive. So we, back in the day, we ended caffeine in treatment. And then Dr. Cardwell Knuckles, I hope you're sitting down, but he said, actually, for meth use disorder, caffeine in moderation can be helpful. So we went back to caffeinated coffee in treatment, but we like you said, people are going to abuse it, and if we weren't careful in watching monitoring how our clients use caffeine, they tended to misuse it. And there are high intense caffeinated drinks, there's pills, other things that create this stimulant effect, and it can be addictive, and it can be a problem. So while we use caffeine in moderation at the instruction of our neuroscientists, we're still very, very aware that people are susceptible to abuse it, especially if they have a history of stimulant use disorder. So, but that's something that needs to go out to the youth too, and it could just talking common sense, it could be like a gateway drug into stimulant use disorder, the caffeine high. And now you're going to get some prescription pills with the amphetamine. See how that link could happen, and then from there into meth, and then so it potentially could be a gateway. But we don't have any research on that. But it's just makes sense.
This person presented to the emergency department and thought he was having the staff thought he was having an anxiety attack, the heart palpitations and sweating and things like that. And it was an accidental overdose with long hours and working, etc. But how about other folks? Other folks have some questions. How about the ability to get some of these resources that you've mentioned? Will some of those be available?
Which
the matrix models and things like that.
Yeah, we could probably create some linkage for those those things.
Thank you.
And then our the seven direction model. That's I love sharing that. So, and I've gone and done 2-day workshops and treatment programs that wanted to utilize the 7 direction model. So that's
thank you.
That can be adapted, but very effective for meth.
So I have a question on when you were talking about the meth addicts that had to sober up in prison.
Yep.
Yeah. And how did that go again with the negative atmosphere?
Yep.
And
Yep.
recovering. I didn't catch that, or I got 2 different things out of that.
So the social climate, the atmosphere in prison, it's a pretty dark and negative influence. So all of the thinking errors that are that manifest with addiction in prison, they're not considered thinking errors. Those are survival tools. This is the way one guy shared with me. Actually, we had a person who was in our program, and it was pre-sentence, and he was looking at many years in federal prison. And if he successfully completed, that would, of course, help him, but he was still looking at many years in prison. And he had a history of being in prison. And about a third of the way through our program, we're a long-term program. It was 9 months to a year. And he was with us for about 3 months. And he made the decision. He was so radically changing and being overhauled in his thought processes, his thinking errors getting corrected. He said, I'm going to be going to prison for 3 to 5 years. I think his guidelines were, up to, I forget what they were, but they were fairly high. And he was obviously definitely going to prison to spend some years in prison after he completed treatment. And I think that if he didn't complete, he was going to get like a minimum of 8 years. If he did complete, he was going to get a minimum of 3 years. It was something along those lines. And in the course of treatment, he was so radically being overhauled, he made the conscious decision. He said, Ed, he said, I can't use this stuff in prison. He said, they're going to eat me alive. So he asked if he could talk to his attorney, and he actually negotiated with his attorney to terminate treatment. He said, I want to go do my time first, and then I want this on my way out of treatment, out of prison, when I go back to the street. So he's the one that actually recognized that, and kind of helped me to see that too. I couldn't believe that he made that decision. And the attorney was said, no, complete treatment. He said, no, he said, I don't want a complete treatment. He said, I don't want to go into that prison system treated and healthy. He said, this ain't going to help me in treatment in prison. He said, I know what I need to do to survive in prison, and none of this is going to be useful. I thought that was just an incredible insight. And he did. He terminated, and he went, and he went to prison, and he's hoping when he gets released that he'll be able to come and complete his treatment program. But that type of environment, if somebody stops using meth, and here's the principle, what Cardwell Knuckles told me, the brain is going to spontaneously, it's going to heal up from the meth, the damage done by meth. When you stop taking the meth, the brain damage ends. Now, during the process of the brain rewiring, recircuiting itself, if you can engage a person, correcting the thinking errors and all of that stuff, and engaging them fully with spiritual, this is new information, that type of thing, that is optimum treatment for somebody with a meth problem. If you stop the meth use, the brain starts healing up. It's going to spontaneously heal up. But if they do it in a prison environment, you see what's happening? The brain is healing up. Yeah. But it's on top of addict thinking errors, dishonesty, and all of that stuff.
That's very interesting, and I think maybe more, and obviously you probably think the same way, that this should be actually studied and documented, because it sounds like to me that someone in recovery from meth in the right atmosphere could actually learn their native languages easier. Yep. or faster, because if it changes the thought process, that's what quotation mark normal people need to do in order to learn the languages and get out of that way of thinking that's invasive culture has put on Native people.
Right. So the language, the culture, the spirituality, a relationship, a living, supernatural, dynamic relationship with the Creator, all of that is built into our program. And people that are brain damaged from stimulant use disorder, if we get them while the brain is rebuilding itself, and then immerse them in this new way of thinking, addressing the thinking errors and introducing spirituality. And they can take their pick. If they want to do Christianity, that's fine. If they want to do some other spiritual whatever, but as long as it involves a relationship with the Creator, the 12-step model is a good example of that. Or if they want to re-engage or engage traditional Native culture, spiritual practices, in that year with meth treatment, it creates an optimal environment for the brain to get established or reestablished that way. So, and I've seen it.
That's awesome. That's really a positive that I will try to promote over here.
Yeah.
Because it's really like a do-over then.
Yeah. Yeah, it actually creates an opportunity for a person to experience life better than they ever could have. But we have to engage them. We got to get them.
Yeah. Thanks.
John?
Hello, my name is Selena. I work with the Red Lake Band of Chippewa Indians here in northern Minnesota. And one thing that we deal with here is a lot of polysubstance use disorder, where we are treating opiate use disorder primarily. However, the individuals that are in our MAT program are still testing positive for methamphetamines. So I know some people have asked, well, is there a MAT program that is available for meth? And we don't have something like that as of now. And then we were wondering, like, are there pharmaceutical medications that people have been using to help them get through or recover from meth addiction?
Yeah. Well, interestingly, there is no medical protocol to treat meth, psychiatric only. So as psychiatric symptoms manifest, appear, or get recognized, then we treat those symptoms with the psychotropic. Probably one of the most prevalent is the anxiety. So we're gonna treat that probably with Ativan or something else. But we got to be careful because they're going to want to misuse this stuff.
And some of those benzodiazepines that are used for anxiety are not recommended when they're in a MAT program utilizing buprenorphine as well. So we're kind of caught in like a catch-22 situation, which one do we treat, which one do we, medicate for versus which one we do treatment counseling and behavior modification for instead.
Yep. So typically the doctors, the psychiatrists that we've utilized, they're not going to give any no stimulants at all. But the anxiety is one of the things that may need to get treated. The hallucinations, auditory, visual, tactile, quite often they're going to need to be on the medication for those psychotropics. They treat it just like paranoid schizophrenia. So and we've had some that didn't respond well to this medication, and we're monitoring them very closely. We've got Dr. Dan and Rebecca Foster meeting with them sometimes several times a week as they're getting their medication adjusted, and we're going to find out just exactly what's going to work best for that individual. So but there really is no medication for meth specifically. It's the psychiatric conditions is what we can medicate. And that's you need a psychiatrist. That's I'm a strong advocate. We need psychiatry involved, and I don't want to go negative, but I've met quite a few psychiatrists that really did not have a really good functioning understanding of meth-related psychosis.
I've asked for sent out just a brief question to the group, small group, about focus for the next session. And if you have a chance to answer that, if you haven't, please let us know. We're going to try and use those results to help direct us in next month's session when Ed will return. As long as he hasn't scared any of you away, hopefully we'll meet again next month for part 2 of this session. I want to honor everyone's time. We are at the top of the hour, and I appreciate all of you staying with us for this presentation. I want to thank Jeff Woodolter and Donna Enfield, and of course, Ed Parsells for sharing some knowledge with us regarding this difficult and challenging area of substance use disorders, the stimulant use disorders, particularly among Native populations. So Ed, again, I want to thank you and thank you all of our participants today. It looks like we may be focused on treatment next for the next month's session, but we'll take that into consideration as we put together next month's webinar part 2. I would also encourage you to consider which type of CEU you would like. If you want to reach out to me directly here at the university, I'm going to post my contact information, and you can reach out to me directly. We're still trying to refine a system, better system for requesting CEUs. I will be inquiring with our comms team about reaching out to each of you with a follow-up email so we can make the slides available today in PDF version for you to utilize. There's a lot of resources there, a lot of information. But I'm just posting this is my email contact. Let me know which type of CEUs you would like, either the NADAC approved substance use CEUs or the social work CEUs, and we'll get those certificates put together and get them out to you as soon as possible. But I want to thank everyone. We'll meet again in October for part 2. Jeff, what's the date on that? I want to look at my calendar real quick. We'll make sure. I know Donna will be getting invitations. The 7th of October, same time. We'll go 9:30 to 11 a.m. Central, and hope to see you then. And spread the word. See if you can get a few of your colleagues to join us. We may be emphasizing and focusing on treatment and intervention. So again, thank you, everyone. Have a great rest of the day and enjoy your extended weekend if you have the opportunity to do so. Thank you again. Stay safe, stay healthy, and stay connected. Until next time. Thank you.
Are you and I and Ed staying on, and Jeff? For
Yeah.
a few minutes?
Yeah, we could.
Thank you.
Okay. I think everyone's off.
Yeah. Whew.
Yeah. So Ed, I was blowing up your phone, trying to give you updates on time, how much time we had left.
Oh.
And I also noticed that there was one slide that I did not want you to put up. It was that summary slide because it had HTC on it. I couldn't stop you, but I did pull it down as soon as possible. And then I just quickly redid the slide and put it back up.
Okay.
Without the HTC logo on it. That's the one I missed. So
Nice.
hopefully with a small group like this, no one's going to say, hey, I wonder what's going on there.
Yeah.
But that was the only issue that I had, just making sure that you're able to check your phone or the chat. I was blowing up the chat box too.
Just make sure that I think we said we we're going to make available a PDF version of the PowerPoint. So make sure those are scrubbed.
Oh yeah, the version that I have now is
Okay.
Yeah, is HTC free, HTC logo free.
And
That's just an oversight on our part. I think what we need to do for next month is just make sure we have a little review of that.
I got a whole deck of PowerPoints. I think there's like over 200 slides that I have for meth. So I'll break out a concentration. It looks like it's going to be focused on treatment.
I think so. I think we had a small response to that polling question, but it looked like there were more
Interested in treatment and an
Two
intervention.
for,
I
yeah,
can do
two
a,
for treatment, one for intervention. Yeah.
yeah,
And if time permits, and we have a small enough group, could maybe do both, but yeah, treatment.
Yeah, and
Uh,
I think it would be worth looking at, maybe some specific examples, especially Ed, with your experience in working with Native populations,
Mhm.
and then maybe referencing to some of the discussion you had with the local spiritual leader there.
oh, yeah, I forgot all about.
That
Ah,
might be good
Bonnie?
too, just to
Mhm.
tie in to tie in some of the discussions you had with Bonnie about, the Bemidji area, and just to give it
Mhm.
a little more.
I meant to reference that, but I didn't have anything to prompt me there, so I just blew right
Yeah,
through.
I think just having a slide in, just
Yeah.
a slide to prompt you or something in your notes
Yeah.
would be helpful.
Yeah, I
I was-
thought about her a couple times as I was doing this. I'm going to do it. I'm going to do it. And
I
then-
was trying to text you. So I think probably having your text, just glance at your phone once in a while. It might be good, because that's the only way I was trying to
Yeah.
give you times,
Yeah. Yeah.
30 minutes, 20 minutes, just counting you down. But we did good. Time-wise was great. I thought we did great time-wise.
Thought
That
about
was-
mentioning about Bonnie, but I didn't want to put you on the spot, publicly here.
I know.
So-
Well, maybe we can do that at the beginning of next the next one.
Now she are there other now she did mention when the way our conversation went, she thought that I was non-Indian and this was a non-Indian audience,
Oh,
and we were going to educate them about the Native perspective. So she was trying to orient me to the Native perspective, and I'm like, whoa, 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 whoa. So and then when we did get to the meth, I don't think she's had any experience with meth
mm,
psychosis.
okay.
It seemed to be just kind of a fresh something that she, I mean, she was flying by the seat of her pants, answering and working with me on what to do, but she kind of she seemed to think that meth addicts don't even have hallucinations, they have spiritual experiences.
I wonder if would you like for me to try and link you up with Dr. Travis Townsend? He is a Native psychiatrist.
Oh, wow, that would probably be good too.
Okay.
Um,
I don't know how much because of liability that he would, be able to state, but I'll leave that up to him. He's
Yeah.
associated with the University of New Mexico, and he is one of our Bemidji area employees who provides telehealth services. And he is also data waivered, and he does actually a lot of teaching for MAT programs.
okay.
So I think he would be an excellent resource for you.
Yeah. With the Suboxone medication assisted treatment for opioids, but psychiatry is really like I shared. I've never met somebody with a diagnosis of meth use disorder that didn't experience meth related psychosis, not one. And of course, when I was in DC, Rockville, they flagged me anecdotal. You can't say that. We can't use that information. We can't. The research says 60%, up to 60%. So I'm just saying, that probably needs to be looked at a little more closely. And it is an issue. And like I shared, we've had some that had meth related psychosis as a diagnosis long-term that went through 2 treatment programs and it didn't get picked up on. So that's significant.
Well, yeah, one of those things in my experience, I have never met anyone who didn't, right?
Yeah. Yep.
We have a little time to plan for this next one. Looks like it'll be an emphasis on treatment or intervention ed. So maybe we just maybe we can do another planning call. I think we should have one on the books here coming up. I think those are just set. Looks like we've got one. Looks like we've got one for the 13th, I think. Yeah, 10 a.m. on the 13th.
Yeah.
So we can talk more then, and yeah, we just got to get you to multitask, Ed, on your to check your phone while we're going, if you want times.
Yeah. Yeah.
If you want a timekeeper. If otherwise, you can just. I know you've got the atomic clock in your mind, so I know I'll let you keep track that way.
Well,
Jeff?
I'm trying to be.
Oh, I'm sorry. Go ahead, Ed.
No, I was just gonna throw something out funny that's not even funny, but.
Jeff, I'm wondering, is it possible to, is there a way to put a little clock in the corner periodically that?
Not that I know of. I think that's
okay.
a pretty good feature at the Zoom, though.
Yeah.
In the PowerPoint, I got a clock. I just it's right there. I can see my clock. I actually got 2 clocks. One's on the PowerPoint, one's on my computer. I can see them both, but I just don't look at them.
I was waiting for you to say Dane Brandage, and I was just hoping you'd get that in there so we could I could give you a hard time about it, but it just didn't happen. Dang it.
Well, I'm a student of traditional ways, so I just follow the sun with time, and I'm in the building, so I'm screwed here.
The texts weren't working, the chat wasn't working. I sent 2 carrier pigeons and was trying to do some smoke signals, but I don't think you saw any of it because
I seen my phone going off, and I'm like, "Who's bothering me? I'm busy. I didn't even."
It was me.
I see that.
I kept saying stimulant use disorder is the clinical term.
At the end, I picked it up, and there's 7 messages from Steve. I wonder what he wants. Let's see here. I think I'll go ahead and read those now.
I think I see a tendril of smoke emanating from your phone there.
There should be a couple of little puffs should have come out of there. And the carrier pigeons should be there in about an hour. So when they start pecking on the window, just let them in, feed them, and then you can read the little scroll note I put on their leg. Oh boy. Now we got through it. I thought it was good. It was good information. I admittedly, Donna, I am honestly disappointed that we didn't have more of an audience, but what can you do?
Me too.
I mean, we put it out there.
Yep.
I think people are being pulled back into the work world, and they're doing more direct services, and we're just having a hard time getting an audience.
Okay.
My last question before I step off is, do we want to try and this is your call, Don, do we want to try and open this up to others to get a bigger audience to see if there's
I would.
Yeah.
I would. As long as it doesn't exceed your platform, I would like to, because I really want to be able to report to leadership that we have been able to provide this education. I truly want to share this educational opportunity with a wider audience. And, if it can't be the Bemidji area folks, let's just share with whomever is looking for this information. Let's get it out there.
Agreed.
Agree?
So let's talk about that in our planning call and see what we can do to broaden this. And I think it needs to be done through your folks as far as how you want to promote this. If you want to expand the audience, then I'll let you distribute that link, and that flyer as you would like.
Okay.
Okay,
Okay, I will ponder that and we'll make it work.
and we'll get the CEUs. I got your request and one other, so we'll
Okay.
get those CEU certificates. Jen Knight with the school social work's been great. We got the last batch out to everybody, and I think Luther was the only one that requested the NADAC CEUs, so
Okay.
that should have gone out to him as well.
And our
Anyway,
our flyer's already approved by Public
Flyer's
Affairs
in.
for next one. It's just the introductory slides.
yeah.
You know,
And I did
those are the only
figure
thing.
out, I was able to fix Ed's bio. I think I had it whited out somehow.
Mm.
But I got it fixed. So Ed, we'll get to see your, here, let me show you here. I got it fixed.
There was like some ghosting on there.
Yeah,
but-
it did. It ghosted out, but you can see it there. That's what it was supposed to be. And it was the lettering was all white, so you
Oh,
couldn't see
yeah,
it.
that was gone.
I know.
Your granddaughter looks so excited. That's a cute picture.
I love that picture. That is like my favorite. Love it.
Went trout fishing up in the Black Hills there, and
Oh, that's good. That's good stuff. But anyway, I got that fixed, so we'll have that ready to go next time. I
Right.
just wanted to get your tribal affiliation in there, Ed, and I'm sorry I missed that. So.
I still think we ought to use my Marine Corps picture now. That
Listen, if you want to get that, we should at least share that with Donna so she could see it sometime, because
Yeah.
it's a spooky one.
He's fearsome, huh?
I
Fierce
know.
warrior. Ed, you may have already seen it if you've checked your email. I already sent out a request to Dr. Travis, an introduction.
Okay.
Okay.
All right. Good.
Okay.
I'll be chatting with him, and
Okay.
and then again, Donna or Bonnie, she said that each tribe has their own spiritual, almost like their own system, their own belief system. Is that true, or is there a general one that people subscribe to, or is it that individualized where even each community has their own?
Well, I'm not an expert on the Ojibwe. I'm not Ojibwe. I'm Choctaw, and I can't even claim to be an expert on Choctaw either. But there are differences, but there are still going to be some core beliefs that are going to be the same.
Yeah.
And here it's more the 4 directions, not rather than the 6 or 7. It doesn't mean that the others aren't acknowledged, but we usually just speak about the 4 directions and the medicine wheel. And as far as additional spiritual, I mean, I am so not an expert. But I would say there are some core similarities, but there may be some individual differences from community to community.
Yeah.
Yeah.
Yeah. But she was almost like every hallucination may actually be a spirit trying to be a spirit helper for every hallucination. That's what she was leaning toward.
Yeah.
And then I said, some of them they presented like demons, and that was a wrong thing to say, because she said, well, they got that from the Bible. That's the demons come out of the Bible, and that's corrupted our people's thinking. So if they're seeing demons, that's where that came from. But as far as meth psychosis, I don't know that she was grasping it. So
I'm going to step off, you guys.
Okay.
I've got a long training coming up, so I'm going to
Yep.
step off and regroup.
Understandable. Thank you for all your help, Steve.
Thank you. We did it. So
Everybody.
part 2 coming up. It'll
Yep.
be good.
Okay.
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 Jeff, I'll see
Bye.
you a little bit later
Okay.
for the ESPER training. Okay.
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 Ed, I'm going to try and see. There's a spiritual leader that I met when I was in Mille Lacs years ago, like in 2012, 11. I think it was 11. So a long time ago, 10 years ago. And I'm going to see if I can't track him down. He and I became friends, and then I lost track of him when I moved to New Mexico. I'm going to see if I can track him down because he is just, I can't say enough nice things about him. He is just so wonderful and so willing to share information. I'm going to see if I can track him down and see if he can't help. And if not him, I'll see who else I can find.
Okay. Yeah,
Okay.
I do feel badly about not referencing Lonnie though. So I'm going to
Yeah.
put that in the next slide. I'll put her in there. So that way I can share, just a positive overview of what we talked about.
Okay.
But
Okay.
I'm thinking there might be others there that may, because it didn't sound like she'd had any experience with meth related psychosis. She hadn't encountered that.
Selena Beasley's a wealth of information too. I'll see if I can't get a hold of her and get something from her.
Okay. All
She
right.
knows everybody. If she doesn't know them, then they probably they don't have a lot to share. That's why. Okay.
All right.
Okay. Well, thank you so much. It was very good.
All right. Thank you.
Okay. Take care. Bye-bye.
Later.